Okay, I think we're going to start. We've given you five minutes extra for lunch, as I think it's fair to start already. Welcome everyone to the afternoon session. I'm delighted to be moderating the first half of the session with my colleague Katia Verhamme, who will be moderating the bit on Darwin EU. I'm going to introduce very quickly the two speakers who will be showing you some results from the latest EHDEN studies that we've done. I do not have any slides to speak about EHDEN because I think I've given that presentation so many times that I bore myself every time I do it. But I will just tell you maybe what Patrick didn't say much about EHDEN. He covered very nicely the massive data network that we have catalyzed in Europe for research using OMOP. I wanted to highlight that EHDEN is not only that amazing network, which of course is a very important component of the whole project, but it's also a community of colleagues who work together and want to collaborate and keep working together. There's plenty of additional research that's not related to EHDEN really that's happening in Europe because of that network or facilitated by that network. There's also a lot of cross-fertilization, cross-collaboration, learning. I'm learning a lot from my colleagues in Estonia on pharmacogenomics. I'm learning a lot from colleagues in other parts of Europe, and I think that's a very valuable thing in terms of the capability building that we need to have in Europe for the next generation to be able to continue leading the OHDSI community and many other things. And there's also, of course, the EHDEN Academy, where you'll have all the resources that you need to do a deep dive into OMOP and the OHDSI world and the EHDEN network, more generally speaking. Okay, and lastly, of course, I am extremely proud that we're going to be seeing some results. So EHDEN had two E's. The first E stands for Europe, European Health Data, and the second E is for evidence, and we're going to be talking about the evidence that we have been generating and are still generating before the project closes. EHDEN catalyzed real-world evidence in Europe dramatically. We saw the adoption of OMOP growing very quickly, and during the COVID times, I think that was like the proof that we could achieve a lot together. But still, before closing the project, the EHDEN project ends in October, and we are already very actively involved in looking for ways to facilitate the sustainability of the network and the collaboration. And many of you will have heard about that, and if not, you should watch this space because there's going to be great news about that. But before we close the project, there's a few projects that we want to finalize, and I'm going to invite two colleagues to speak next. Jeremy Dietz is a scientific advisor at the NICE in England, and he's going to be talking about a study that was completed in the last few months. And then after him, we'll have Marta Pineda, who is a postdoctoral researcher at Oxford, talking about the EHDEN mega study, as we call it internally, which is a study on drug shortages in Europe, which we hope will be the biggest study ever done using real-world data from Europe. I'm going to invite Jeremy first to give us his presentation, and we'll hear Jeremy for the next around 10 minutes, and then we'll have hopefully some time for questions. Thank you, Jeremy.
Okay, so I feel like this is a bit of a cursed talk in the sense that I get to go through our results, but I also get to talk to you about health economics. So can I just get a quick show of hands of who has a good amount of health economics background in the room? Yeah, that's kind of what I thought. So this is predicting long-term cancer survival, and before I begin, obviously I just want to give a quick thanks to Danielle, who did all the coding at Oxford. She's been fantastic, has devoted about 18 months to this, so it's been a long time coming. And also Rav, who's also at NICE, and he has been the one that's, wrote the protocol and been working with data partners. And of course, James, who did the dashboard, Ian, who's also at Oxford, who's been, immensely helpful in talking through the extrapolations, and so many others. Okay, so in terms of what we are doing, NICE is a co-lead on Work Package 2, which was enabling the transition towards outcomes-driven healthcare systems. And it also was extending the OMOP CDM and vocabularies to include PROM, so the standard outcome sets. But kind of the main bit was testing whether the OMOP CDM can be used in the context of regulatory approval and health technology assessment and also for payer purposes, which is what I'm going to be talking about. So the use case that we developed is around cancer survival. So when a company wants to get their drug approved for routine commissioning on the NHS, they first have to submit it to NICE. And the main component of that includes an economic model to show not only that their drug is effective, but to show that it's cost effective. The kind of underlying sentiment there being, there's only so much money we can spend on the NHS, and if we spend it in ineffective ways, then we're perhaps not spending it in a way that's going to maximize population health. So in oncology, this is done typically through a three-state model, and this is done with the outputs from the clinical trials, namely overall survival and progression-free survival. So with those two curves, you can generate a three-state model. So you'd have people who are alive, who haven't experienced disease progression, people who are alive, but they've experienced disease progression and death. The issue, of course, is that when companies submit their models to NICE, a requirement with our methods is that you build a model over a lifetime horizon, typically. And this is to show all the important benefits and costs. And the reason for this, if you just think about it logically, some benefits might happen downstream. So if you only modeled over 2 years, you're not going to account for that. And then something that might appear cost-effective actually might not be cost-effective in the long term. So if you're familiar with oncology, I think you can see where this tension starts to come, because if you kind of guess how many months of data most RCTs have, do you think that when companies are doing their submissions, that is going to equate to a lifetime horizon? And of course, the answer is no. Typically, companies are submitting economic models with RCT evidence, anywhere from 18 months of data to 24. Maybe we're really lucky and it's beyond that. So the main kind of way around this is fitting standard parametric curves to the RCT data. And this allows you to extrapolate into the future. And then you have your evidence that you can use your long-term. And that's how you go from the RCT data to the long-term models that we use. So that's like the briefest background for the health economics. The issue, of course, is there's a lot of uncertainty around this. There's typically 6 standard parametric models that are fit, as well as 2 other more flexible ones that can be fit. And when companies do this, this is always a source of tension. It's because the companies will submit their dossiers, but this is also independently critiqued by an evidence assessment group. And if you go through any NICE appraisal, there's always an extended conversation about which parametric model fits best. And there's kind of 2 main aspects to this. There's how well do the parametric curves fit to the actual observed data, so that's based on the actual trial data you have, and how well they can extrapolate into the future. So this is extrapolating beyond the actual trial data. And this could ultimately change the decision. So this could be if a drug is cost-effective and that it's not recommended, or if it is cost-effective. So there's a lot of uncertainty around this. And that's kind of what we wanted to propose, is looking at real-world data, because there's a lot more of it, to see which extrapolations perhaps fit better, and that could hopefully reduce the uncertainty in oncology. So we had 3 objectives. I'm just going to quickly go through these. It was to create a dashboard, describe the overall survival, and then also to look at the extrapolations. In terms of the study, we put out an open call. We had 18 data partners respond, 17 went through the data approval process, 15 successfully ran cohort diagnostics, 13 ran the full study codes, and Tiago, who I know is here, successfully encouraged a few more Portuguese hospitals to run the code. So not only did he run it on the hospital that he works with, but he brought in others. So in the end, we have 15 data partners who participated. This is just a brief slide of kind of the work that Danielle did, and just again to highlight the amount of work that she did. I think the stunning number here is that she fit 1,200 models, and this is just a basis of all the different parametric curves, so the 6 standard ones as well as the 2 flexible ones, and then you go through all the different stratifications, so age stratified, sex stratified. So yeah, just a massive undertaking, and yeah, just really incredible work. So in terms of the actual results, all the data partners have now been fed into the actual EHDEN dashboard. And kind of going through this, on the left-hand side, you have the data set, so you can go through, you could pick CPRD, you could pick CityApp, you could pick the Netherlands Cancer Registry. any of the 15 data partners that participated, you can pick the type of cancer. So we had 7 more common cancers as well as a more rare cancer, which was head and neck cancer. And then the top image on the left is the actual Kaplan-Meier data. So that is the black line. And then you have all the extrapolations, so like the Weibull, the Gompertz, as well as, again, the 2 spline-based models. And then you have the hazard function over time, then you have the at-risk tables, and then you have your goodness of fit, which is AIC-BIC. And for those of you not familiar, those are statistical measures that are typically used to determine which is the best fitting model, with a lower number indicating a more parsimonious model. So in this case, the spline-based models were the best fitting ones, which I don't think is too surprising for anyone who's worked with these, because the splines are supposed to fit the models really well, or fit the data really well. In terms of describing the overall survival, breast cancer across the databases, so we have CPRD on the left and the Netherlands Cancer Registry on the right. We see that breast cancer had some of the best survival, so about 50% at about 20 years. And then in terms of cancers that had the lowest survival, pancreatic cancer had the lowest survival, and you can see that it basically goes to 0 quite quickly. And this is looking at the Geneva Cancer Registry on the left, and then again, the Netherlands Cancer Registry on the right. So finally, we have the, again, this goes back to the extrapolations. So this is, again, showing the Kaplan-Meier curve and then the fit parametric models to it with the goodness of fit, so the AIC-BIC. And again, this is looking at stomach cancer, and you can see, again, that the spline-based models with 3 knots is the best fitting model. So kind of in terms of the last steps here, the dissemination, so we're already working on 3 different papers. I know we're keen to try to get those preprints out by September at the latest, so hopefully everyone will be able to read those in more detail. So Irene, who's here, is working on the overall survival paper, and then I'm working on the extrapolations, and then Rab is working on the federated data analysis, and then obviously we're presenting here at OHDSI. And of course, we have submitted to ISPOR and ESMO as well. And then this is just a picture of the study-a-thon, which again, thanks to CityApp and Talita for hosting. This was in beautiful Barcelona in January, which I think everyone who from the UK team can attest. They were much happier to be in Barcelona in January than in the UK. A nice little break from the rain. And finally, just a thanks to everyone who participated. So yeah, everyone at University of Oxford who helped Danielle, CityApp for hosting us, and then all the data partners, because obviously this wouldn't be possible without them. And of course, everyone in the EHDEN community, as well as OHDSI. And that is all from me.
Thank you, Jeremy, for showing a picture of Barcelona on a cloudy day, and you still were happy to be there in January. I think we're going to hold the questions until we see Marta's presentation, and then hopefully we'll have around 5 minutes for questions. So take a note if you have any question for Jeremy, and he'll come back later. Marta.
Thank you, Dani. So, good afternoon, everyone. Thank you very much for giving me the opportunity to present today our project that basically is entitled Trends Over Time in Medicines with Suggested Shortage in Europe. I wanted to introduce you that there's also this acronym that you might hear that is the mega study, but you already hear the reason why we call it. So we are very ambitious. We want to be the largest study possible. So therefore, let's go and why we pick drug shortages, why they matter. So basically, some of you might be already aware that drug shortage is an incoming issue. Drug shortages, basically, so shortages of essential medicines has a very harmful impact to patients. It increases the rates of mortality and adverse events, and since doctors might be not as familiar to use the alternative, it's more prone to produce drug errors. It also has an economic burden linked to that. And I would like to share you perhaps one example. I think it's very familiar because we all been there, although it every time looks like it's farther away in our minds. And during the COVID-19 pandemic, we know that basically there was a disruption in the chain supply. And basically, you might have heard about friends, family, or even yourself that certain medicines that you were used to use, they were not in the counters in the pharmacies. Another example is that we know that we all needed the COVID-19 vaccine, but the production was not enough for everyone, and we had to prioritize. And basically, it leads that those who had more economical power had basically sometimes the first go. So with all of that in mind, we want to contribute in giving a picture of what's going on in Europe. And therefore, we had these two objectives in our study. The first one was to analyze the incidence and prevalence of medicine with suggested shortages. Basically, we select 25 medicines for that, and then we select 32 alternatives to see how they behave. And then we also wanted to describe this incident and prevalent users of these medicines. So we divide the study in 3 steps. The first one was a feasibility check for the data partners. Then we ran the incidence and prevalence analysis, which is basically the objective number 1. And the next one was the drug utilization study, which includes the characterization for the objective 2. And this here is an overall picture from the inception of the project to what we think is the very end. So basically, we had this idea of the mega study with drug shortages. So what we did is the EMA has a public catalog of the medicines that they had identified as potentially in shortages across Europe. So we got our list of drugs from there. And then we picked the alternative from the literature. Then we used the DARWIN EU packages that were publicly available to produce the 3 steps of our code. We share this code through GitHub with the data partners, and then now we are in the step that we are collecting the results, and later we'll give them back to the community in form of publication, conferences, etc. So the question is, how well done have we done our job in terms of numbers? So you can see here that basically from the list of EHDEN data partners, 72 give or express their interest to participate. That then transformed into 49 data partners who sent their feasibility results, and of them we had 47 that basically account for 55 databases that have the minimum requirement that for us, just to be a participant with your database, we require at least have 1 drug of interest. It didn't matter if it was one of the drugs of shortage or if it was one of the alternative, and we require at least 100 patients in the study period that was 2010 to 2013. And this latest note, if you're an EHDEN data partner, you still haven't participated in the mega study, there is still time, so please contact us. We would love to make it big and just keep calling the mega study. So the next step is the incidence and prevalence step. We are still receiving results, but at the moment we have received 33 databases, which basically you can see, yeah, maybe it's a bit small, but we have a broad representation of different type of sources. We have hospitals, we have primary care linked or not to hospitals. We also have registries and claims data. And we had, I think it's 13 countries in the moment, or at the moment. And then for the drug utilization study, since we released the code later, at the moment we had received 19 results. So a sneak peek of what we had received, of how the result will look like. So again, this is just preliminary results for the incidence and prevalence package using some of the data partners who already have IRB approval, so we could share and display the results. And you can see there is a long list of drugs, and it's challenging to analyze them in one go. So all the results had been implemented in a Shiny app where we can later just like go across in much detail. And we plan to basically distribute and analyze the drugs by different type of groups. For example, one could be the antibiotics for common infections, but there are other like cancer or transplants or even smoke cessation, among others. But again, this is a major task. So this next Thursday, actually, we are planning a webinar where all the results will be analyzed in much depth by all of the data partners who agreed to participate. And also I wanted to talk about what were the challenges with this big analysis or big study. The first one is the scale, and the first point is the project management task, and we couldn't do that without the help of Monsek and Robi, because basically she was the first gate of any of the data partners contacting to participate in the mega study and keep chasing them and keep engaging them. So massive thank you to Monse there. Also, it's fine. Yeah, thank you. She's been a true lifesaver for us, because then Teresa and I could just focus on the code and also helping the data partners running their study. The next challenge was the timelines. And basically, the largest number of data partners you have, of course, we know that all the data partners may have all the commitments, but we have to get the results on time, and we have different timelines. But we managed to make this a study that people could join at any moment. And the last one is, at least for the scale, is the output of results. As I mentioned, we have a large number of results, and we really want to have this webinar with the data partners to try to see what are the key highlights. And then the other challenge we had is that we had a lot of data partners who were joining for first time, and that means they needed some help. But I think our team managed pretty well, or otherwise, please let us know. And this is just to give you an overview of how the timelines of this whole study had been and how are been. So we start with writing down the protocol in October, and we were just releasing the code in different phases. We always expected, hopefully, that the data partners would send the results in 3 weeks, although, as I mentioned, that was not always the case. For example, there were people who didn't have their databases ready when the feasibility results were released. Never mind, we had this first strong date to send the results. That was the 13th of May, because those who had sent the results by then, we will share the results in this upcoming webinar this Thursday. And just to mention, for those EHDEN data partners who want to participate, there is still time to register. The registration ends today, so please scan the code. And that's all. Thank you.
Awesome, thank you so much, Marta. Yeah, drug shortages is definitely one of those hot topics. We've had a lot of interest from many stakeholders in Europe, and I think this is going to be producing, it's one of those where you will have probably 1, 2, 3 papers, and then a massive database with a lot of results that people will be using without us knowing, probably. We have something like 5 minutes for questions. I don't know if anybody wants to start. Patrick was trained in an American university on American football, so he can reach anywhere in the whole room.
Including the balcony. See you guys up there.
Any questions, anyone?
What is the definition of a drug shortage?
Tricky one, because that was given by the EMA list for us, so it was easier to pick. So basically, to be able to be in the catalog with as a shortage, you had to be, some countries, more than one country in Europe, has to have this phase when they cannot supply the drug of interest, basically. Basically, there will be not enough counts to supply the whole population that they need. So if you would need 100 patients, maybe you would only have doses for 50.
For how much time?
So usually, it's hard to tell. What the EMA does, basically, is they report in the catalog that there is this, not enough drugs for everyone, let's say this slang way. And then they report they update this information. And once, basically, the providers tell, we are okay, we produce enough drugs, they just say that the drug shortage was resolved.
Do we have anyone from the EMA who wants to answer that question with more context? Because I know there are some colleagues from the EMA here. I know the FDA has a very specific way of defining drug shortages. Because I remember I was chairing a session in ICPI, and there was a whole presentation on this. But I think Marta told you the concept, but I don't know how it's done here. I know there is a kind of expert group that works on drug shortages, but I don't know the method behind it.
You got a question over there.
Okay,
Ready?
let's go for the question then. And now you know why Patrick didn't make it into the NFL.
I have a question about when it's data that you want to submit to the competent authorities, either EMA or either FDA. So when it's real-world evidence studies, you can not submit the raw data for reanalysis. So how is it perceived by the authorities when submitting results of real-world evidence studies?
Let me try and summarize. I think the question is, how do the regulatory authorities perceive real-world evidence even when they don't receive the raw data from the different data partners? Is that your question?
Yes, exactly.
I'm not sure this is, maybe do you want to comment on how NICE handles this? Because we don't have anyone from the EMA here. I know there's some people around. Maybe they want to answer, but.
Yeah, so our data and analytics team has produced a nice real-world evidence framework. So that's been like a useful thing for industry to kind of go through as they're preparing their submissions. I know kind of a continued point of contention is we want to see a more systematic approach to how companies are selecting their real-world data, because I think off the top of my head, the appraisal that comes to mind was one that it used data from Flatiron in the US as well as a German chart review. And then obviously it becomes a question of, okay, why did you pick those two? NICE committees tend to prefer data from the UK. So it would have been preferable to see UK data, but if there's a reason for that, it would have been, good to see. And yeah, I think we're just kind of pushing companies to be more systematic in how they identify their real-world data and submit it to us.
I think I can comment from the experience of working with regulators without having ever worked for a regulator, but I think most of the time, similar to what Jeremy was saying, I think the challenge is more about what data sets were selected, why did you choose those ones, and then increasingly there is a need for increasing transparency in terms of how did you create your phenotypes, what are your lists of codes or conditions that you use to create your phenotypes, and increasingly something positive is that there's also an appetite for more transparency in terms of coding, right? So sharing the analytical code as well. But I've never been asked to share the patient level data because there's, GDPR would prevent you from doing that, right? But there's an increasing appetite for transparency and reproducibility in the whole pipeline, which I think is in part, maybe I'm not going to be too humble here, but in part due to you guys and the OHDSI community pushing for that agenda. Not everyone has been pushing for that same thing, so I think it's something to be proud of. Unless there's any final burning question, I'm really keen to pass it on to Katia because I know she has a lot of data to present. Thank you so much, Marta and Jeremy.
So good afternoon. Now the time for some Darwin results. But before we do that, perhaps it's not bad if I give you a short update on the Darwin project. So the title is The Large-Scale Evidence Generation in Darwin EU. And with the disclosure, so what is Darwin? So it has been initiated by EMA. It's a federated network of data, expertise and services that supports better decision-making throughout the product life cycle by generating reliable evidence from real-world healthcare data. And the different partners and the important partners for this project, you can see that on the slide. So at the middle, you have the coordination center. At the left, you have EMA with respective committees. And then, of course, crucial is having the data partners with the respective data sources. So the way it works, EMA and the committees, they have specific questions and they come to the coordination center to check whether studies are feasible or not. And if, we then check with the data partners whether the data partners have the data, and then we decide then EMA decides whether to go ahead or not with that specific study. Data partners are important, and you can see that on this slide. So in year 1, we onboarded 10 data partners, and they are colored in green. And in year 2, we onboarded, again, additional 10 data partners, colored in yellow. Nicely spread, but not completely spread yet. Different type of data sources, so primary care data, secondary care data, registries, biobank data. And we are still looking for data sources to further enrich with different type of data sources and to have an even better geographical spread. So we are looking for additional data partners and with the aim to onboard 40 data partners in total. If you're interested to join, on the website of Darwin, you can find the link to the catalog of real-world data sources from EMA. And then this slide in particular, and I'll give you some time to have a look at it, but this is the way, this is the place that you can use if you want to register as, or if you want to show expression of interest to join as a data partner. Now, some background on a number of studies. So we are now in year 3. Last year, we submitted, or we worked on 14 studies, 14 off-the-shelf studies. We did 4 complex studies, but you see from year 3 on, the number of studies is much larger. So we are going to do 30 off-the-shelf studies. Off-the-shelf studies mean that we can use existing pipelines. We will do routine repeated studies. The aim is to do 12 complex studies. And in year 4 and year 5, the number of studies is even increasing, where in year 4 and 5, we aim to do 145 studies. What type of studies are we doing? And this is a slide that I received from EMA, nicely explaining the differences between the type of studies. So I spoke about the off-the-shelf, routine, repeated, and complex, but this brings it in another, so more from the question itself. So the studies that we can do, like disease epidemiology study or drug utilization study, that's mainly to understand the clinical context of a condition. We could also do studies mainly as a support for planning and validity of studies that have been conducted. And then we have the more complex studies where we look into effectiveness, safety, but for instance also measuring the impact of a regulatory decision. I received a slide from EMA as well. It's a quite kind of busy slide, but it shows nicely the studies, the completed studies that we have done so far, respecting the type of studies, like looking into disease epidemiology or conducting of safety effectiveness studies, or studies to check whether future studies are possible. What is nice on this slide as well, that you also can see at the bottom which committee or who asked for that specific study. So that could be CHMP, PRAC, for instance, but also national competent authorities or health technology assessment. So this is the list of completed studies. And then we also have ongoing studies, again, with the same color pattern. If you want to know more about these studies, you can find it on the website of Darwin, and you can also go to the website of EMA on the catalog of real-world data studies. And I think this is a short introduction to the studies that are going to be presented, and the first one is by Annika. Annika is a senior researcher in pharmacoepidemiology at the University of Oxford, and she's going to show you treatments of opioids in Europe.
Thank you, Katia. Thank you so much for the opportunity to present this study today. You just saw there are lots of interesting studies that have been completed. And one of them was the Darwin study looking at the trend of prescription opioid use in Europe. And you see a lot of names on the slide already, which shows that this is always a team effort, doing these kind of studies at the speed and the quality that we did. That's the disclosure. Okay, what was the rationale and the background for this study? As you all are aware, opioids are highly effective for managing severe pain, so a very important class of drugs, but obviously also a kind of drug that is very making people at risk for getting addicted if they use them for longer than needed or in higher doses. So there is, at the moment, although the media, the talk about the opioid crisis going on, particularly in North America, with increased inadequate opioid prescriptions that led to people getting opioid-dependent abuse and, unfortunately, a lot of fatalities associated with that. So more recently, there have also been growing concerns in Europe due to an increasing use of opioid and related mortality. So the question that we were looking at was like, what is the situation in Europe? And the objective was to evaluate the trends of prescription opioid use and to characterize new opioid users in different European countries. We did this study with 6 data partners. Many of them are probably here in this room, so that's wonderful. We used the IPSI database, CDAP, and IPD, Germany and LPD Belgium, and that was primary care data and outpatient secondary care data. And then we had the Bordeaux University Hospital providing data from the hospital data, and then the Estonian Biobank. So 6 databases with a broad geographical spread. The study population for this study were basically all people that were registered in the respective databases as of the beginning of each year, and we looked at a period from 2012 to 2022, and all people who had at least 1 year of data availability in the respective database could be included. We looked at different exposure definitions. So first we were interested in all kinds of opioids, and then we had different cohorts looking at the strength of opioids, and that was defined by the WHO analgesic letter. So we had weak and potent opioid drugs. We looked at opioids by the route of their administration. So we had cohorts for oral drugs, injections, and transdermal opioids. And then we looked at the active drug substance, and those were already like 35 different drugs. So in total, a lot of different cohorts. We defined new users as people who didn't have a record of the respective opioid, and that could be the substance class or the individual drug substance in the year before their treatment initiation, and as a sensitivity analysis also in the 6 months, which means that we had 80 different cohorts that we were characterizing. We started with looking at the population opioid utilization, and we used the Darwin standardized analytics for that. We calculated the annual period prevalence of opioid prescriptions, and that was calculated as a number of users in the study population per year using the incidence and prevalence package. The package is available on Crown if you're interested in using that, and yeah, very well documented. And there's also been a publication recently out about that if you're interested in having a look. In addition to the prevalence, we also calculated the annual incidence of the new users, looking at new users over time, and the study population basically for that denominator then obviously excluded people who have been using the opioids as prevalent users. That was calculated by 100,000 person years per year. And then we stratified for calendar year, age groups, and sex. And I want to show you this first graph looking at the prevalence of overall prescription between 2012 and 2022. And you directly see that I kind of grayed out a little bit the time from 2020 to 2022, because that was obviously the pandemic, and there was a lot of disruption in people having access to healthcare and prescriptions. So when we want to interpret the overall trend, we kind of like leave that a bit aside for a moment. As you can see, in 2012, there was a very difference in where the different prevalence for the databases started. So we had a few databases with higher prevalence, about 8% in IPSI and CDAP, and then databases with slightly lower prevalence, about 4%, in Estonia, France, and Germany. Broadly speaking, the prevalence was largely stable over time. So we do see a bit of a decrease in Belgium and a bit of an increase in Estonia, which was in line with the previous literature, but overall the trend was fairly stable. Those numbers are largely driven by the prescription of oral opioids and also by the prescription of weaker opioids such as tramadol and codeine. And when we look at the prevalence of stronger opioids, and that is oxycodone, morphine, fentanyl, and hydromorphine, we see a slightly different picture. So while the prevalence started at a lower level, we see that there is a trend of an increase, particularly in the hospital in France and in IPSI, and I think that's something that's quite important because those are the drugs and the types of opioids that if people get addicted to them and abuse them, they have a higher risk of later problems, and there are higher fatalities in these populations. Looking at the incidence, new users, I think it's very nice to see that we do see a bit of a decrease. So particularly in Belgium, there is a substantial decrease in the incidence of users, but also in other primary care databases such as IPSI and CDAP. The opioid use was highest in older adults. I think this is something that we would expect. And again, the new prescriptions, mostly codeine and tramadol, decreased over time, which I think is also a good finding. When we looked at new users, patient-level opioid utilization, we first characterized new users with a large-scale patient-level characterization, and that included demographics, the history of comorbidities and communication at the time when they started the new treatment, and also in the time before. In addition, we were interested in what were the potential indications for the prescriptions, and we approached that by looking at which conditions were recorded at the index day and in the week and month before, and based on that on concept IDs, so in a data-driven approach. Lastly, we looked at the duration of the first treatment era, and the first treatment era was in this case defined as repeated prescriptions with not more than 7 days between the end of the first prescription and then the subsequent prescription. We used the patient profiles and the drug utilization package for that, and they are also available on Cron in case you're interested. Okay, let's have a look at the new users. Looking at the age distribution, I think it's quite striking that we see people across all age bands. So, for instance, between 30 and 70 years, that's the usual range. Depending a bit on the databases, people in the hospital were slightly older with a median of 57 than in primary care. And in primary care, we also see that the higher numbers of new users were seen in females. When we think about the indication, the primary care and outpatient databases show that there are a lot of prescriptions for cough, common cold, other respiratory tract infections related to cough, whereas you see in the hospitals, the indication is more about complications and pain, and that is the same in the Estonian biobank. Looking at the duration of treatment, when we look at all opioids across the databases, we see that the median duration was very different in the primary care and secondary care databases in the outpatient setting, between 1 and 2 to 3 weeks, compared to the hospital where we only had people using that for 2 days in median. However, when we look at the different substances, there's a bit of a different picture with weaker opioids that are used for cough, such as codeine, for instance, and CDAP, that are only used for a week, and then fentanyl, hydromorphone, which might be used for cancer-related pain or in the setting of palliative care used for more than 3 months in median. The results that I just showed are just like a small snippet of what we did. And there is a whole shiny web application that comprises all other results, including the large-scale characterization. And that is the example for IPSI. So if you, on your way back home, want to look at something, there is a lot to explore in the big shiny application. And as Katia said, the results are published and available on the webpage and in the reports. So please have a look if you're interested. So in summary, I think it's good to see that the prevalence of use of opioids was largely stable. We indeed see a decrease in new users in many European countries, which is also reassuring. We saw the highest use in older adults, and the most common indications were respiratory conditions and pain-related conditions. And as to be expected, we saw that the treatment duration varied quite between the settings and between the opioid substances. And with that, I would like to thank the study team, particularly Frank and Mike for leading the study, the data partners who are participating. That was great to collaborate and great to see these interesting results, and also to the EMEC colleagues who were involved in that project. Thank you very much for that, and thank you all for your attention. And that's it. Thank you.
Thank you, Annika, for that great talk. And we now have another presentation of one of the Darwin studies presented by Talita Duarte Salles. She's a colleague of mine, assistant professor at the Department of Medical Informatics at Erasmus Medical Center, and you are also leading the real-world epidemiology group at EHDEN.
Thank you, Katia. Hi, good afternoon, everyone. It's a real pleasure to be here today to present this Darwin EU study on multiple myeloma, patient characterizations, treatments, and survival in the period of 2012 and 2022. I think this is almost the last talk of the day, so I hope you're still excited to be here and be ready to listen to a lot of results that we've produced with this study. These are the disclosures. And here's some, before I start, I would like to start with some rationale and background for this study. So multiple myeloma is a plasma cell malignancy which represents from 1 to 1.8% of all cancers globally, and nearly 10% of all hematological malignancies. Its prevalence is actually increasing over time thanks to increase in life expectancy, but also thanks to improvements in the survival rates. In fact, survival rates have improved in the past decades due to better management of the disease and the development of new medicines. However, still only 10 to 15% of patients achieve or exceed the expected survival when compared to the general population. So there's still many patients who are not responding to treatments. So the rarity of the disease makes it challenging to have a clear picture across Europe of the characteristics of these patients at time of diagnosis, the different therapies that they receive, and their overall survival. And this is what we did here. So these are the objectives of the study. The first thing we did was to describe the demographics and clinical characteristics of patients with multiple myeloma. We then described their treatments and treatment sequences. I'm not going to present the results for treatment sequences today for sake of time. And finally, we estimated the overall survival of these patients between 2012 to 2022. And how we did this, so we included all individuals with a first diagnosis of multiple myeloma between the study period of 2012 to 2022 who had no prior history of cancer. And we created 3 cohorts that I'm going to explain in a little bit. But these are the databases that we included in the study. We had IQVIA Germany, the CDAP database, which was a primary care database in Spain, IMASIS, which is a hospital database in Barcelona, Spain, the Estonian Biobank, the clinical data warehouse of Bordeaux Hospital in France, and the Netherlands Cancer Registry. So very different types of database included in the study. And actually you see that different databases can help answer different questions. So the first thing we did was the large-scale patient level characterization, where we described all comorbidities and medications that were recorded in different time periods prior to the index date. The index date in this case being the date of multiple myeloma diagnosis and at index date. And then for cancer treatment, we described all the, like a pre-specified list of treatments that were recorded at index date and then in different periods post-index date, this being like 30 days, 90, or a year after the diagnosis of multiple myeloma. And finally, for survival, we calculated overall survival based on the data on time of at risk of death from any cause, and using the Kaplan-Meier method. We showed the results using the plots of the estimated survival curves and the estimated probabilities of survival at 1, 3, and 5 years. We presented all results by database overall, but everything also stratified by age, sex, and study period. And these were the packages that we used for the study: cohort diagnostics, patient profiles, treatment patterns, and cohort survival. Actually, this was the first study to use cohort survival. It was developed for the study, so this was very nice. Thanks to the Oxford team for developing that. And here is the study population. So this, you can see the overall number of patients in each of people, individuals in each database. And then the different, so this is the attrition table. We included people with no prior history of cancer. And then I think what you see in the first cohort was the one that we used for the large-scale characterization, where we required patients to be in the database for at least a year. And I will explain a little bit more later, but here you have, so the number of patients, multiple myeloma patients included in each database. So the smallest database in this case was the Estonian Biobank, and the biggest was DA Germany with more than 12,000 patients, followed for NCR with also almost 12,000 patients. The median age went from 66 in Estonian Biobank to 75 in EMACIS, in Spain. And in terms of distribution by sex, what we saw was that in, I think, Bordeaux and NCR, there was a higher frequency of males than females, while in Estonian Biobank you had more females. And then in DA Germany and CDAP and EMACIS, it was quite balanced. So yeah, here I just have one slide for the results of the large-scale characterization. As you can imagine, there's a lot of results, and we also have a Shiny app, all the results are there with the different time periods. But here is just a summary of the main comorbidities that we observed at time of diagnosis. We didn't observe differences by sex, and sorry I didn't mention, but yeah, things like hypertension, osteoarthritis, hyperlipidemia, renal impairment were quite common. We didn't observe differences by sex, but when we looked into different age groups, we did see that in younger age groups, we also see things like anxiety, depression, and asthma as being one of the most frequent comorbidities, while in older individuals, we saw that renal impairment was one of the most frequent comorbidity. I'm not showing the results for medication, because I would like to spend some time to present the cancer treatment results. So this was cohort number 2. So for this objective, we did not use data from CDAP and DA Germany because we didn't have data on cancer treatment there. And here we required that patients had to have a potential minimal follow-up of 30 days. So these are some results. This is actually the frequency of the different treatments during the first year after the diagnosis of multiple myeloma. Focusing a little bit in the different classes, the most frequently used drugs in this case were glucocorticoids, chemotherapies, proteasome inhibitors, and immunomodulatory agents. We didn't observe, I'm not showing the results stratified by sex, but we didn't observe many differences there. Actually, there was no differences. And when we looked into age, we actually saw that immunomodulatory agents and proteasome inhibitors were less used in people older than 70. So this was one of the findings. And then finally, the survival analysis. So here, we didn't include data from DA Germany because we didn't have date of death in that database. And here we required a minimum of potential follow-up of 1 year. And here you can see the restricted mean survival, the 1, 3, and 5-year survival in each database. And as you can see, for CDAP, NCR, and EMACIS, this was quite similar. It was around 5 to 5.7 years, while Estonian Biobank and Bordeaux had much higher survival, so around 7 and 8 years. So when we looked at differences by sex, we didn't observe a lot of difference, but you did see that males have a slightly lower survival than females. When we looked into age groups, we saw what we expected, that older individuals had lower survival compared to younger individuals. And when we stratified by period of time, so we looked into those patients with a diagnosis prior to 2017 compared to those that were diagnosed in 2018 or later. We didn't see huge differences, but in NCR and CDAP, we do see that the curves start to separate after 3 years. So ideally, it will be really nice to have a longer follow-up to see if this improvement in survival is actually happening in these databases. And sorry, I did not show the stratified results in Estonian Biobank and EMASIS because they were small, so it was a little bit difficult to visualize the results. So yeah, here are some conclusions. I think here, I mean, this was a very summary of results. We produced a lot of results, as you can imagine, but we provided a characterization of more than 30,000 patients with newly diagnosed with multiple myeloma in between 2012 and 2022 across Europe, making this one of the biggest, if not the biggest study done so far in multiple myeloma patients in Europe. We found that these patients had many comorbidities and medications at time of diagnosis, meaning that these patients are probably not represented in randomized clinical trials. We also saw that the most frequently used treatments were glucocorticoids, followed by proteasome inhibitors, chemotherapies, and immunomodulatory agents, which is in line with the guidelines. Yeah, as I mentioned, we saw that these two classes of drugs, so immunomodulatory agents and proteasome inhibitors, were used last in older individuals. And finally, the survival probabilities varied by age groups, with decrease in survival observed with older age. And yeah, I would also like to thank healthcare professionals and patients for providing the data. Also, of course, data partners who contributed to this study, the study team, the colleagues at EMA, all the Darwin CC colleagues, and of course, the OHDSI community for everything. So thank you very much.
Thank you, Talita, for also a very good talk. I'm really proud of the results of the Darwin studies. For sake of time, I think we have time for one question for the opioid study and one study for the multiple myeloma.
Yay! That was very nice. We need to get this box for other symposia. Thanks so much for the presentations. That was exciting. My question is for Talita. This is an amazing study. I'm sure a lot of work went into that. I saw that there is a substantially different survival, 5-year survival. And do you think it's because of the different death capture or because the populations are different?
That's a good question. Thank you, Anna. For Estonian Biobank, we're not sure. But for Bordeaux, we did explore this a little bit further because we realized this was a problem with how observation period was mapped. So basically, we were only capturing deaths that occurred during hospitalization. And we were missing, they have a linkage to register, so they had the deaths that were occurring after, outside the hospital. So they need to change something in their mapping, and we rerun this and see what happens then. But it's an issue with the observation period. With the Estonian Biobank, we are not so sure. But yeah, we need to explore that a little bit further. Thank you.
Okay. And now one question for the opioid study. There must be some.
Yes, perfect. All right, ready? Here we go. Nice shot.
I'm fine.
All right, so I noticed that there's a decrease in opioid use in times of COVID, right, from 2020 to 2022. So it comes to my mind that opioids can be used in surgeries, in post-operative periods. So there might be a decrease, not because of we getting better and we just, start making it less, but maybe there were less planned operations, and that's why there were less opioids, right? Did you test this hypothesis?
I think that's a really good question, and to be honest, we don't really know. I think there's a lot of potential reasons why we see this decrease in opioid prescriptions during the pandemic. And I think you might have seen that in 2022, we do see that there is a bit of an increase, so we don't know yet if in the future we'll go back to like the base level in 2019 that we saw before, or what happens after. So I think that's going to be very interesting to see. There can be lots of reasons, as you said, a delay in surgeries. There can be like just differences in access to GP or other clinician. So we really don't know yet. I think that's an interesting one to do, but that was out of the scope of the study.
Okay, thank you so much. Can I ask another follow-up question?
Quick one.
Short one.
Yeah, okay, thank you. So with that results, what can be other steps, next steps? Like we know that it's increasing, or we know it's decreasing. Mm-hmm. So what are the potential uses of that information?
Well, I think the idea was to first get an overview of what's happening. And I think the next step would be, as you said, trying to understand more details. I think there's a lot of data out there in the Shiny app now that we can use for that. So I think one thing that I, as we said, particularly think it's interesting to see what happens after the pandemic. So if we have a few more years of follow-up to see if we go back, and if the trend that we see now in the decrease or in being stable prevalence is still the case then, or if there is any change after the pandemic.
All right, thank you so much. And where is the link to this Shiny? I should ask that.
Okay, I'll make sure to share that.
Okay, thank you so much.
Thank you. Thank you. So, thanks so much, and then we can close this session and move to the next session.
All right. Who's had fun so far today? Who's had fun so far today? The balcony didn't have any fun? Those really are like the peanut gallery up there. That's fine. Okay, so I don't know about you. Personally, I can tell you that my head's spinning because there's been a lot of things, a lot of different diseases, a lot of different treatments, a lot of different research questions that have been answered and really great research during the Collaborator Showcase. This session, which is only going to be about 15 minutes or so, is going to put you all to work because we collectively need to decide what we are going to be doing together that's going to be even more amazing at next year's OHDSI Europe Symposium. So the first thing that I want to do is, if you think you might want to come to the OHDSI Europe Symposium next year, can you stand up if you're able? Okay. All right. Okay. And I want you to look around, and I want you to high five somebody who you knew before coming to this session today. Okay. And now I'd like for you to high five somebody who you met today, somebody you didn't know before. You got to reach around, find them. All right. So I had a lot of fun conversations like over the lunch break where people did express that they were probably a biased sample that came to talk to me, but that expressed that they had a lot of fun in the community and asked why this was different than other scientific meetings. And I think a large part of it is because we are trying to put an emphasis on the community and the we. This is a great scientific conference where lots of great science was done, but I think it's actually more important that we're here with individuals who want to be able to participate and collaborate together. So you guys, if you want to, you can sit back down. But I am going to still put you to work. I hope that you got a little bit of blood working. The issue is that we, as a group right now, need to decide what evidence we are going to showcase at OHDSI Europe in 2025. So to do that, I'm going to need your help. And hopefully we can switch over to the laptop. I'm going to ask you guys to go to a website. It's polev.com/PatrickRyan800. You should be able to scan this QR code on the screen as well. You can do this with your phones, your laptops. We want you to be able to go over there. And actually, I better make sure that it's actually set up. So give me 1 second for that. Yep. Let's say activate. There we go. All right. So you all should be able to go to the website polev.com/PatrickRyan800. Hopefully you can scan that top corner there. And you're answering the question, what evidence should we generate together and showcase at the OHDSI Europe in 2025? I'll wait a second. So what I'm going to ask you to specifically to do right now is I want you to think about what you learned today, what you saw, and specifically what you didn't see, the thing that you wished you saw the community do. And for right now, I just want you to enter in your ideas as see if you guys have any good ideas. Throw in what evidence should we generate together and showcase at the OHDSI Europe. And for right now, I just want you to put in ideas. It's perfectly good if you see ideas that are coming through. But for right now, I just want you to share some ideas. I see we got some meta-analysis, health economics. You don't have to upvote and downvote yet. We're definitely going to do that over the course of the next 15 minutes. We can see time trends in cancer survival. Apparently, Talita was ahead of her time. And we're going to see how patients with breast cancer were treated. Time trends. Oh, we could talk about GLP-1s and side effects. Suicide, mental health. We're already starting to get quite a range of various different topics. I want you to, we're going to be using this app throughout the next 15 minutes, so stay logged on, enter in your own thoughts, and you should also be able to see the other things that people are posting so you can scroll through. Now, let me flip over here. Okay. Now, I trust you all can come up with a good idea for what evidence are we going to generate to showcase at OHDSI Europe in 2025. But I trust let's see, activate. I trust my my OpenAI overlords even more. So I'll ask them the question, what evidence are we going to showcase at OHDSI Europe in 2025? Perhaps this will give you all ideas of things you might want to put in our chat. So it thinks we should have new research findings. They're a hell of a lot better than old research findings. We should integrate clinical trials and real-world evidence. Maybe we should have some methodologic innovations. Maybe we should collaborate. We should apply some OHDSI tools. We should do some patient-centered research. Health economics, so we'll get more friends, we'll get more hands raised next time. And more opportunity for education and capacity building. So, okay, so I don't feel like GPT was actually very much help. I hope you guys are continuing to enter in more specific things, because that seemed like more like platitudes of stuff that we do rather than specific questions. Let me pivot over just briefly to, actually, I don't think we saw this slide earlier today, so I'll highlight this slide specifically. You actually saw really great demonstrations of the different analytic use cases that from the very start were the explicit goals of what we were aiming to generate evidence for the OHDSI community. We think about characterization as studies of basic observation, descriptive statistics to summarize a population. And you saw really beautiful examples from Annika on opioid use and from Talita on multiple myeloma, where baseline characteristics of populations can be extremely important just to understand the burden of illness, the patterns in healthcare, and that can be tremendously useful. We also think explicitly as a community about how we can work on population level effect estimation. So answering questions of causal inference about examining the safety of a medical intervention or its comparative effectiveness. And the third area that we focus on is patient-level prediction, so applying machine learning algorithms to draw inferences about the likelihood of an event in the future. So as you're thinking and continuing to enter on your phone, I see some of you people put your phones down, you still should be entering feverishly all the good ideas that you have. I encourage you to think specifically about, given that these are the 3 analytic use cases that we in the community are trying to think about generating evidence for, what questions can we answer in these cases? And one of the things that I've actually, over the last couple of years, come to appreciate more and more is that we started with this idea that we needed reliable evidence. We put a lot of effort into data standardization and to standardized analytics that could be applied to standardized data. But I think the actual hardest thing of all of this, as hard as it is to ETL a data set and as hard as it is to write reliable code that doesn't error out, I think actually the hardest part is to ask a really good question. Because if you don't get the question right, you're doomed from the beginning. And yet it's really hard to think about asking a question like I just asked all of you, what evidence do we need? Because it's basically completely open-ended and you can write whatever you want and it can be interpreted anyway. And we have created this rubric in the OHDSI community to think about trying to standardize research questions into this template, whereby basically if you can fill in the blanks for any of our questions of clinical characterization or population level estimation or patient level prediction, by standardizing the question, that enables the opportunity to do standardized analytics, which enables the opportunity to have standardized evidence. And as Katia presented in terms of Darwin, there's no way that we as a community or a project like Darwin can scale to hundreds of studies a year if we don't first figure out how to standardize the question so that we can standardize the analytics so we can standardize the evidence. If we want to do something together, we actually really probably need to come up with a basis for thinking about what questions we want to ask in a more formal way. So I was talking there just so that hopefully you were looking at these templates and maybe populating some ideas into our chat. But I thought also, let me break out of here. I thought also maybe I would, so actually let me check. Did you guys do it or you guys are way too quiet? Did anybody enter a specific templated question yet? Not yet. Not yet. Okay. Oh, somebody did. All right, nice. Okay. We got lots of ideas. I see lots of people already voting up ideas that they find intriguing. And we've got some editorials in here too. All right. So as you are looking through the list of things that we might want to do as a community, I want you to think about how can I contribute to that? How can I take action? How can I participate in that activity? We got a lot of good stuff, which is great. I want you guys to keep throwing in ideas. Okay, but I don't see very many yet following the template. So maybe our OpenAI overlords will be a little bit more compliant to the template than you all are. Let's see. Using the OHDSI standardized rubric, question rubric, define a research question that is clinically important and is a current evidence gap that the OHDSI Europe community can generate together for 2025. And I'll paste in our rubric. Yes? Well, I'm sorry, Ari, go ahead. Oh, yeah, so I'm currently using ChatGPT 4.0, which also has the ability to search online. So it basically is sufficiently near real time in terms of its current knowledge. All right, so what did it do? I actually didn't even pay attention to it. So research question using the rubric, okay? So they're suggesting, our overlords are suggesting that what we should study is, does exposure to SGLT2 inhibitors increase the risk of experiencing diabetic ketoacidosis within 1 year following the start of exposure? Oh, they give us a reason why. These drugs are widely used. They control glycemic control, but there's a concern that they may be associated with diabetic ketoacidosis. Evidence gap. There are some reports and small-scale studies suggesting a link between the drug and ketoacidosis, so a large-scale study could do that. By focusing on this question, the OHDSI Europe community can contribute valuable insights into the safety profile of SGLT2s, ultimately guiding better clinical decisions in patient care in the treatment of type 2 diabetes. All right, is anybody convinced by GPT? Is that what we should do? Oh, we answered this question already. Indeed, we've actually published in the OHDSI community a network study on diabetic ketoacidosis with SGLT2s, and within our Legend type 2 diabetes study, we have a wealth of results that are already about that, which probably suggests that our evidence dissemination strategy in our OHDSI community could involve a little bit of improvement. All right, the good news is, though, our GPT overlords could actually follow the instructions and take our little template and fill it in and give us a question. So we don't like, you're saying, Anna, we don't like this question because we already answered it even if they don't believe us. So, okay, let's run it back then. Let's see if they can give us a better idea. I hope that you're still typing in ideas. Hopefully you're thinking, I can do better than a chat bot. Well, it looks like GPT loves them some diabetes. All right, so they're now asking for a comparative effectiveness study of SGLT2s who have a different risk of experiencing heart failure within 2 years of exposure relative to GLP-1s. Anna, is that in Legend type 2 diabetes? Yes, it is. In fact, actually, our paper's been accepted to JAC that answers explicitly this question, but I guess it's not in print yet, so we could maybe give OpenAI a break on that one. So have people been entering in better ideas than this? I can go all day. 5 minutes, perfect. Very good. All right, so thank you. So I want you to keep entering in ideas. I'm gonna have you go look at that in just a second. What I want to actually encourage you to think about is the universe of real-world evidence that we could be generating if we were to work together. I'm drawing here a matrix of all indications and treatments, of which there's more than 2,500 different distinct indication treatment pairs in medicine. And there are over 10,000 conditions that exist. This entire space of every indication, every treatment, every outcome, that represents an opportunity for us to think about generating evidence. We could do something like Annika just showed very nicely. We could say, let's take one particular treatment or a class of treatments in opioids and just ask, what are the treatment patterns for those? That would be extremely valuable. We could take one specific outcome, and as Talita showed, we could take a particular disease and ask, like, what is the incidence of a disease and what are the progression? And that would be extremely valuable. We can also take the intersection between a treatment and an outcome and ask a very explicit causal question. Does exposure to drug I increase the risk of outcome J? This entire matrix is possible. Currently within our OHDSI, we can also do a prediction study. So what's the probability that a given patient will experience outcome J after exposure to drug I? Currently in the OHDSI community, what I saw actually today and what I've seen previously is we're doing pretty good as a community at answering individual questions. Like we did our Save Our Sisyphus challenge last year, and we had an ophthalmologist come with a specific question: do anti-VEGF treatments increase the risk of acute kidney injury? And we're able to take a very small space of this universe, and together as a community, we worked for 8 consecutive weeks, and sure enough, we executed a very large network study that in under 12 months actually resulted in a very nice publication. So that's something we can be proud of. We've also been demonstrating the ability for our community to do large-scale analysis. And so the LEGEND effort that we've done has now been done through multiple diseases. We started with depression, we worked through hypertension, and we now have multiple papers on diabetes. And the basic construct there is to say, let's not ask one drug, one outcome at a time questions, but rather let's think about collectively a space. Can we take all drugs that treat hypertension? Can we take all outcomes related to antihypertensives and systematically fill that gap? George Ripsack has been actually promoting the community that we actually need to think even bigger. We need to be thinking about how we can actually fill this entire space. And specifically, he's leading an effort within our community to think about how do we do large-scale incidence analysis such that we could understand the frequency by which all outcomes occur for all drugs. All of these are really good opportunities, whether you've got an interest in a particular drug, a particular outcome, a particular estimation study, a particular prediction, maybe a space that you're interested in, maybe a larger space, maybe you have ambitions to take on the whole thing. What's most important to me, though, is that we think about how we can collaborate together, however big or small, so that we can identify the big opportunity in front of us. So I'm going to go back to our form here, and I'm going to put it back into the mode. So with that as a precursor, we're going to spend the last 3 minutes here. I want you to look through the list of ideas that you all came up with. Think about the biggest impact that we could have to increase, to promote healthier decisions and better care for patients around the world. What are we going to do as an OHDSI community that we're going to showcase at the OHDSI Europe Symposium? What I'd like for you to do is review the posts that are in there, and I want you to go through and I want you to, if you think that that's the really good idea, I want you to upvote it. You can push the little thumbs up. If you don't think that that idea is the most important thing, you can give it a thumbs down. But I want you to take a few minutes right now and please vote on that. I will point out very specifically, this first one as a very specific example. Data quality is critically important to what we do as an OHDSI community. We clearly need to have rigorous standards for data quality and data standards that we put into everything. But I want you to ask yourself the question, are you going to be super excited if next year you come to the symposium and the big reveal is a presentation on data quality? I'll be here anyway, but I want you to think about what is going to be that thing that we can do together that is going to fundamentally reshape healthcare, is going to make you proud about the evidence that you've generated, that you've delivered to the world. The big opportunity that you probably can't do by yourself, probably can't do it within your own institution, probably can't do it with your couple neighbors around you, but is possible if we could take the 350 people who are in this room who collectively have access to Europe's largest data network, and in consult with the rest of the OHDSI global community, have access to more than 12% of the world's population, to generate answers to questions that matter to healthcare professionals, to patients, to regulators, what have you. I want you to vote on that. I'm going to leave it open for quite a bit of time. Still, guys love some data quality. You get one more minute till Peter's going to yank me off the stage. I'm hoping that what we're going to see here is a question that we are all worth going after. So I see in data quality, more researcher-friendly sharing of ETLs and mappings, ETL methods and tools, women's health, drug safety, data quality, quality of data, regular expressions, mental health. Oh, there's NLP, that's awesome. Cancer treatment outcomes, suicide and mental health, meta-analyses. All right, I'm going to leave this poll open, and of course, I want you to listen to Peter as he closes us out, but I also want you to reflect very seriously about what you want to do and what you want to contribute. This is your community, this is our collective community, and we want to do together what we think we can do to advance our mission and vision. I want you to be thinking big, though, and not thinking only about what is the narrow thing that you can do, but what can we do together as a community. I am sure we are going to advance improvements in tools for ETLs. I'm sure we're going to improve data quality. I'm intrigued by women's health as an area that's chronically been underrepresented and is potentially an area that we could focus on. But I want to hear from you, and we're going to actually collect this information. We'll share it with a broader community, because I want it hopefully to become a charge not just for you all and not just for our OHDSI Europe community, but as a target that we can think about for the entire global community. So please do share your ideas. Thank you for those who have entered in your various ideas. Please take some time to continue to report it. But with that, I'm going to turn it over. Before we jump ahead to thinking about 2025, I think Peter would like to make sure that we close 2024 with a bang. So I'll hand it over to Peter.
Okay, thank you, Patrick, and thanks everyone. I have the honor to close the symposium this year again. And I think we are really on a journey, and I like to refer to this nice picture of Odysseus in his journey in the Odyssey. It's very nice, actually, that on this specific paper on the top it says it's not very clear what route Odyssey actually took to come home. And that is also true, I think, for our community. We have different ways to get to our targets. And Odysseus had interactions with all kind of gods and all kind of challenges, and we are having the same challenges, or also challenges in our community. And that's also why in Odyssey we use a lot of names, a lot of characters that are from this journey for our tools. And there's a huge number of tools actually that we have. And there's also question marks. So if you have another tool in mind and there is still a god available or a character, please propose it because we need to expand this list even further. What's also really nice is that we have a large number of work groups in Odyssey, and that's really your option to participate in the work that Odyssey is doing. It's really a large number of them, an endless list almost, with new initiatives that have been started in Odyssey. From Atlas, from the tools, clinical trials, common data model in general, but all kinds of specialized things as well as eye care, etc. So a very long list. I'd really like to invite you to have a look at that on the Odyssey website. There's also community calls, which I can highly recommend, because in these community calls you can learn what the community is doing, but also you may contribute yourself and actually share some of your own ideas in these Tuesday meetings. There's an Academy of EHDEN that you can use to learn more. I got a lot of questions from people today, and also the mentor meetings were really nice. A lot of questions on where can I find more information, and the EHDEN Academy is definitely a very interesting resource for that, with many, many active learners all over the world. More than 100 countries have participants in this academy, so it's really nice to see that. Also want to mention the OHDSI Europe, or the OHDSI US Symposium is open for registration. I've been there, I think all of them, and it's really very exciting to be in that larger community, and also very nice to see a lot of European representation in these meetings. But as Patrick said, I think this is the moment to increase our impact. We are in a perfect storm. We have a lot of data. We have a lot of things to do, and we can really start doing that now at scale. And especially in Europe, because we have a very strong focus on improving the interoperability of data and using that, and also have the capacity in place now to further improve our data model and analytics, and do that together as one community. This is also our moment to publish many methodological publications and to improve our established best practices and make some major steps also in improving semantic interoperability. I think this is a very important topic for Europe, and I really look forward to work with on that with many of you. We need to sustain and maintain a network and generate reliable evidence in Europe at a global scale. And I think this is really a fantastic journey to be on together. And I think this is just the start of many, many, many nice things we can do. This is the moment. This is the day for impactful studies in every way. Every endeavor we have made together is coming into play. It's here and now, today. This is the moment. This is a time. Our analytics and data are in rhyme. Give me this moment, this precious chance. With patient journeys from the past, we can make some sense at last. This is the moment when all we've done is moving these data, schemas and vocabs into one. This is the day. See it sparkle and shine when all we've worked for becomes prime. For all these years we faced the world as one, and now the time has come to prove to all the work we've just begun. This is the moment, our final test. Science beckons, we never settle for second best. We won't look down, we must not fall. This is the moment, the sweetest moment of them all. This is the moment, damn all the odds. This day or never, we sit forever with our Titan gods. When we look back, we will always recall, moment for moment, Odyssey's moment, the greatest moment of them all. Thank you. Thank you, thank you, thank you, thank you very much. Thank you. Thank you. It's a very special moment because it's the fifth time that we do Odyssey, and I thought we had to do something special. However, I could not do this by myself, and there's a couple of people that I really like to thank because they have been instrumental in these 5 years. And it's many people from the Erasmus team that help out. If you're in the room, please come forward. I would really like to have you here in front of the stage. And definitely Tineke. Tineke, where are you? Tineke. Tineke, if you can come up on the stage.
Wow.
She has done an amazing job, so thank you very much, very much. However, I would like to invite actually all the speakers of today. So if you have spent like a minute on this stage, please come up because we have something for you as well. So please come up on the stage. Every speaker, so that means everybody in the front, everybody from the national notes, join us. And we have a small gift. It's actually a tulip. It's a wooden tulip, and it has the Odyssey logo on it. So you can actually put it on your desk in a cup, in, for example, the nice Odyssey cup that you got. So please join me on the stage. Spread out a little bit. No, I like you a bit more in the middle. I'm sorry. Yeah, you need to be exactly in the middle. Very good. It's good to see the number of people actually that have contributed today. They're almost there. Now, there is another reason why I put all these people on the stage. Because I've been trying to get some background vocals, background dancers for 5 years, and it never worked. But I thought this is a good opportunity to put them behind me. And so we're still going to do one other song, and I hope you will all join with that. And I would like to invite everybody in the room, just stand up because you cannot sit down with this song anyway. Okay, thank you. Everybody look around, but there's a reason to rejoice, you see. Everybody come out, and let's commence to singing joyfully. Everybody look up, and feel the hope that we've been waiting for. Everybody be glad, because the silent fear and dread is gone. Freedom, you see, has got a heart singing so joyfully. Just look about, you owe it to yourself to check it out. Can't you feel a brand new day? 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 Yeah, and you see some proof that Martijn Schuwe was on this stage playing the bass. There he is. Everybody be glad, because the sun is shining just for us. Everybody wake up into the morning, into happiness. Hello world, it's like a different way of living now. And thank you world, we always knew that you'd be free somehow. In harmony, let's show the world that we've got liberty. It's such a change for us to live so independently. Freedom, you see, has got a heart singing so joyfully. Just look about, you owe it to yourself to check it out. Can't you feel a brand new day? 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 Yeah, and watch Patrick doing a fantastic dance in just 5 seconds. Everybody be glad, because the sun is shining just for us. Everybody wake up into the morning, into happiness. Hello world, it's like a different way of living now. And thank you world, we always knew that we'd be free somehow. In harmony, let's show the world that we've got liberty. It's such a change for us to live so independently. Freedom, you see, has got a heart singing so joyfully. Just look about, you owe it to yourself to check it out. Can't you feel a brand new day? 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 Come on everyone, can't you feel a brand new day? 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 Thank you very much. Thank you. And thanks everybody on the stage for your contributions. Thanks a lot. Thank you. We have one more thing to do, and that is make a group picture. And for that we need Martijn. So we're gonna be, not? Yeah, yes, we need you, right? I was a bit worried now. No. So we're gonna take a picture from here to there. So everybody's gonna be in the room as we did last year. So you can go back, otherwise you're not on the picture. That will be a problem. So we can all stand there, and Martijn is gonna make a very nice group picture at the end. Yeah, please from the balcony, if you can come down, because you will not be on the picture if you're there. Yeah, very cool. At least it stays, it's not going away. So we have to move a little bit to the center from both sides. So it's going to be a little bit close, but we have a lot of people. But Martijn has a fantastic camera, I've been told. So he can... oh, you're really going to do a trick here. We go. Yeah, that's true, that's true. Okay. I'm not sure if we can get a little bit more light in the room itself instead of directly to the stage. Is that possible? Just to switch on the little bit more light in the room? Yeah, that's better, I think. Yeah, thank you. Some people in the back, move a little bit to the center. Yeah. Martijn, can you check how this looks? Almost good, almost good. Because now you're going to do a circus act. And that he's going to be on the table. Can I help you? Yeah. I'm not sure if this goes well on the top. Yeah, sure. Yeah. All right. You need to be in the line. You guys have to squeeze in a little bit, and you guys have to definitely squeeze in. So my ankle length is actually that one. Squeeze. Okay, so Adi, you are not in the picture right now. This is getting more difficult every year, Martijn.
I was thinking the same.
Thanks, everyone. If you have any posters still, try to get them now because they're going to clean the room. So if you want to keep it, just get your posters. Thanks, everyone.